Bismillahirrahmanirrahim. Hi everyone. Again, we're back with the ACGME six core competencies, and today we're going to talk about the second one, which is the medical knowledge. Okay, so the first sub-competency under medical knowledge is applied foundational sciences, and basically this is really what you learned during medical school. So hopefully the resident will be able to go from being able to explain simple pathophysiology of common diseases to be able to integrate scientific knowledge to address uncommon, atypical, or complex conditions. So I can't really emphasize that enough. Always remember to go back to basics. What you learned during medical school is really would be the foundation for your career. And for any reasons, if you feel like that foundation was not solid, it's still early during your internship time to try to build that even further, because again, the foundation is a foundation. It has to be strong, and always try to go back and study the basic pathophysiology about especially the common diseases that you get to encounter on a daily basis. And then always think about why these diseases happen. I would suggest that you know about the Occam's razor versus Hickham's dictum. These are very interesting two concepts. So basically, the Occam's razor, it says entities should not be multiplied beyond necessity, meaning one should shave all unnecessary and remote explanations and come up with one or two simple entities that can explain most of what's going on with the patient. That's basically Occam's razor. And the opposite of that is Hickham's dictum. So Hickham's basically stated that patients can have as many diseases as they damn well please. So basically he's saying that it's not uncommon that patient might have more than one disease entities happening at the same time. Occam's saying, well, it's probably one pathology, one basic thing that's happening, and we need to reach to the bottom of that. So that's really the main difference. Again, in real life, you might see cases that fit Occam's razor. You might see other cases that might fit Hickham's dictum. But really, the whole idea is always try to think about getting into the bottom of the problem and start solving the problem from bottom to top, not the other way around. And then this is a simple phrase that I really like, which is, if you cannot explain it simply, then you do not understand it well. And then this probably sometimes comes up when you're talking to your patient to try to explain to them what's going on and what are your findings and what are your plan and management plans for your patients. So if you find yourself struggling, that might mean that maybe you're still not really sure exactly what's going on with your patient, and you need to think twice about understanding what's going on, and then come back maybe in a later time when you really know exactly what's going on with your patient and try to explain it in a simple way. But generally, if you really, for example, if you're giving a lecture or giving a topic or a morning report, if you feel yourself again struggling presenting that topic, maybe that you really need to go and study more about that topic. And then always know the resources available by your available for you that your program will provide. For example, UpToDate is a very popular one. Dynamite also, most of the program they provide ACB subscription to the residents. New England Journal of Medicine, they have a lot of resources that you can look at. But really know these resources and have a regular study plan to read regularly and study regularly, whether that be in conjunction with your program or even for your own sake, to improve your medical knowledge, which is really very important core competencies, as you probably know. Basically, if you don't know how to treat your patient, your patient care will be really poor. So take a look early at the beginning of the internship. Ask the program coordinators, ask your seniors what are the resources available for you, and try to know which one you like, which one fits your style of reading more, And if you have suggestion for your program, something that you like, ask the program and see if they can provide it for you and for your colleagues. That would be great. Be proactive and try to improve your program. Another important sub competency is under Mechanologies, the knowledge of diagnostic test. So basically, or residents should be able to, at the beginning of their training, to explain rationale, risk, and benefit of for common diagnostic tests that they order on daily basis, whether that being a laboratory test or imaging test or any other diagnostic study, to go into level 4 and 5, where they can integrate test characteristics of various diagnostic strategies in complex and complicated patients. So basically, we're our program expecting the resident to be able to know or have a good idea about the sensitivity of the diagnostic test, its specificity, the positive predictive value, negative predictive value, and the likelihood ratios. Doesn't mean like you have to remember the exact numbers. I mean, of course, if you can do that, that's okay. But you can really memorize all the numbers for all these tests that you do on a daily basis. But at least know that it is just this test is really good, very sensitive or not, or poorly sensitive or not, or specific or not. And we talked about the likelihood ratios when we talked about the evidence-based physical examination. So you can go back to that video hopefully and kind of learn more about it. But basically, a lot of diagnostic tests, lab tests, they have likelihood ratio negative and likelihood ratio positive. That can be really very helpful on a daily basis when you're managing your patient. And then try to think about the diagnostic test from the window of the test being the best initial test and the test being the diagnostic test for certain pathologies. Usually the initial test would be a simple test that has minimum harm or less cost, and then the most diagnostic test. Usually, but not always. Usually, it's a little more expensive and might have some other adverse effects associated with it. So, for example, if you have a patient coming with subacutely with diabetic wound and you're suspecting osteomyelitis of the foot, then depending on the time frame, you might think that ordering an X-ray of the foot might be really the best initial diagnostic test, because if it's suggest osteomyelitis, then with the clinical suspicion, then you have your diagnosis. But keeping in mind that if it's negative, then maybe you need to do the more appropriate diagnostic test, which might be the MRI with and without contrast, or the CT scan with and without contrast if MRI cannot be done, and so forth. So yeah, think about that aspect of when it comes to diagnostic test. What is the best initial diagnostic test, and what is the most or best diagnostic test to reach a certain diagnosis? And then, of course, try to know about the diagnostic criteria for various diseases. Sometimes these diagnostic criteria were done really for research purposes, but a lot of time they're actually very helpful in clinical practice as well. For example, we always say that irritable bowel disease is a diagnosis of exclusion. And does that mean we have to exclude every single cause of abdominal pain or diarrhea or constipation? Of course not. So there's some diagnostic criteria for that, and you need to, in the appropriate clinical setting, you need to think about the diagnosis that you need to exclude first before you make the diagnosis. But knowing the diagnostic criteria would be very useful, and this is part of the medical knowledge that we expect the resident to be aware of, especially for important diseases. The third important sub-competency under medical knowledge is, of course, the therapeutic knowledge. So at level 1, residents should be able to explain basis for common therapies and medication that they prescribe for their patients. And at the graduation level, they should be able to integrate therapeutic knowledge within clinical and psychosocial context for complex patients, and be able to oversee and look into the list of the long list of medications that some patient might have, especially elderly, and trying to tackle that problem of polypharmacy for those patients. So this is really very important sub-competency A resident expected to know what are the first line medications or drugs for certain pathologies, what are the indications and contraindications for these medications, and what are the side effects that are to be expected, what are the side effects that should tell their patient, and how to monitor these side effects. Also, another important aspect that you should know is really the drug-drug interactions, especially again with patient with polypharmacy who has been prescribed a lot of medications. We have seen it really quite often that some patients are being prescribed multiple medications that actually interact with each other, and some of them are actually contraindicated with each other. And it's really important that residents evaluate the medication list for their patient during every visit that they have in the outpatient, and also on a daily basis during the inpatient encounter as well. And then patient education is really key. Whenever you're prescribing new medication for the patient, you have to tell them about that medication, what to expect, and why you're suggesting the medication. You have to, again, think about the interaction that might happen with this new medication to the other medications. And also, really important that to tell the patient about the side effect that they should expect, and what to do if they develop these side effects, and how to minimize these side effects. Patient education is really key. And, in the era that we're living in with a huge availability of many numbers of medication that are available for us to prescribe, I think it's really an element that's really key, and a little bit, I think, personally, it's under scored, and a lot of many of us, they don't really give enough importance to it. So I really pay a lot of attention to this aspect. And whenever you're asked to prescribe new medications, try to go and learn about those medications. Even your senior or your attending asks you to prescribe it, go and learn about it. And sometimes you might discover that actually maybe that medication should have been prescribed. As you might expect, there's a lot of ways that the program can assess the learners or the residents' medical knowledge. Of course, the most popular one is examination, your scores that you came in from medical school, your scores during the in-service exam or during any exam that the program assigned to you, and also during the daily work when you discuss a case with your attending, they ask you questions about the test or the plan and what to do, and what are the rationale behind your decisions, and what are the basic pathophysiology behind certain pathologies. So all this falls under the assessment of medical knowledge, and probably I would say this competency is probably the most straightforward competence that can be directly evaluated, in my opinion. But again, can be tricky sometimes. Really, the score during any exam really reflects the performance of the learner during that particular time. It's not 100% reflect the overall medical knowledge 100% of the time. So we are aware of that. But again, if you have a regular plan and you really being very professional in following the instruction of your program, you should be able to really to reflect your medical knowledge in a very reasonable way during these in training or in service examinations.